Hello, and welcome to the National Council on Mental Wellbeing, CCBHC State Technical Assistance Center podcast on psychiatric rehabilitation. My name is Stephanie Woodard, and I'm the managing principal at Bowling Business Strategies. I will be the moderator for our discussion today. This presentation was made possible by the U.S. Department of Health and Human Services. As a reminder, its contents are solely the responsibility of the authors and do not necessarily represent the official views, opinions, or policies of HHS. Additionally, the views expressed in this webinar are solely the opinions and views of the people participating. They do not necessarily reflect the opinions or views of the National Council for Mental Wellbeing, its employees, or partners. We are providing this content for informational purposes only. I am joined today by Josh Cabral, Executive Director at Rural Nevada Counseling, a Nevada-based CCBHC. Josh is a certified substance use counselor and certified substance use counselor supervisor with extensive experience in rural behavioral health leadership and systems development. His experience with CCBHC design and implementation started with the 2016 CCBHC State Planning Grant. Since then, he has expanded access to CCBHC services through access points across several rural communities in Nevada. I'm also joined today by Justin Volpe, Senior Peer Support Coordinator at the National Association of State Mental Health Program Directors. Justin is a certified peer specialist with a criminal justice specialty and a CIT trainer. Justin is a person with direct lived systems experience. He has been a peer since 2008 and has worked and consulted nationally in many different systems. His focus is on bringing siloed systems together to better serve individuals experiencing crisis by providing holistic, person-centered, trauma-informed care. And also joining us in the discussion today is Sarah Dearborn, Nevada Medicaid Senior Chief for Benefits Coverage. Sarah supports and oversees the policy development and program management for all medical, dental, and behavioral health benefits for Nevada Medicaid eligible individuals. Sarah began with Nevada Medicaid about 7 years ago and focused efforts on behavioral health benefits coverage and was part of the team responsible for Nevada's state plan approval for certified community behavioral health centers. Prior to her Medicaid experience, Sarah gained experience in the field of mental health through her work with children, families, and adults, performing and managing psychiatric rehabilitation services at a local Nevada behavioral health agency. She holds a master's degree in marriage and family therapy and has over 20 years of experience in the field of mental health. Welcome to all of you today, and thank you for taking time to sit down with us and talk about psychiatric rehabilitation and what it takes for successful implementation of psychiatric rehabilitation programs in CCBHCs. Before we get started, I want to take a moment to provide some context for our listeners. Psychiatric rehabilitation is one of the 9 core services of CCBHCs. These rehabilitative services are designed to support individuals to develop essential skills, support optimal functioning, well-being, and recovery, and facilitate community living across all domains for life of individuals across the lifespan. Psychiatric rehabilitation includes social, emotional, and educational development. It facilitates inclusion and integration into the community and supports individuals in pursuit of their goals. Basic skills training, psychosocial rehabilitation, supported employment, assertive community treatment, supported housing, and evidence-based peer-led programming, such as whole health action management, can all be part of the constellation of rehabilitation and recovery supports under the larger umbrella of psychiatric rehabilitation services. Justin, I'd like to start the discussion with you. As a person with living experience, how do you see psychiatric rehabilitation services as essential components to treatment and recovery support?
Well, I think it's a huge part. It could be a huge part and work together with somebody on their journey. You know, as a person that has been through something similar 20 years ago, not to the extent of what it's at today or even through the CCBHC model, I think, helping people meet them where they're at, develop some of those skills, job skills, life skills, and really, get them back on their feet, beyond just, the traditional treatment of medication compliant and, sticking to your treatment plan, showing people how to live a life uh, and dream beyond that, and show them how to really reintegrate into the community. I was given that opportunity, and there was no looking back after that. I mean, to teach somebody how to fend for themselves is really what you want to see so that, they don't have to recycle back through the system.
Can you tell us a little bit about the importance of the services that you received in your own recovery journey?
Yeah, absolutely. I was uh I was mandated to a psychosocial rehabilitation through criminal justice intervention in 2007, and begrudgingly went because it was better than jail, but ended up having a lot of support through that network there, and it really helped get me back and get my life back together. I had therapists and counselors and peers and people get me to vocational rehab and to give me intensive therapy and to give me some skills and to learn how to kind of live again. And they were so, you know, understanding, the people I worked with, and not so punitive about if I made a mistake, if I had to return to substances, if I, wasn't doing my medication regimen. And it was more of, you know, let's meet you where you're at, and educate you. A lot of education went into it on, mental health and substance use and uh, treatment and mental health symptoms and stuff like that. Because when you first experience something like that, it's really hard to understand what you're going through, let alone have a clinician explain what they've learned in 7 or 8 years and getting their masters, to break that down to you when you don't understand that language. And I think it was, some of the relationships I made with people in there I've worked with after I turned my life around back in the field, and I've worked with and had relationships with. And I think, if you want to like safer communities, this is, in the criminal justice lens, which CCBHCs, do serve those populations. It's like, we can't just show people, drop them off at treatment and just, hope that they do well without that kind of warm handoff and that, that whole wraparound services. And that's really what they gave me. And they gave me a chance to get my life back. And here I am 20 years later. So it was a very good experience. Even though I was not maybe so appreciative of it at the time, I do look back and really thankful that I had the opportunity to have some kind of treatment like that.
Thank you for sharing your story. Josh, I'm curious from your standpoint as an executive director at a CCBHC, one of the key points that Justin just spoke about was having services available to meet people where they're at. Can you talk a little bit about the importance of your services through your CCBHC and how your staff approach meeting people where they are at?
Yeah, I think one of the most important pieces of the CCBHC model, if I'm being honest, and I think about it like I'm kind of an analogy person, I guess, but therapy is great, and I certainly don't want to downplay therapy. But what we learn is, you know, when people come in and see their therapist, they're in a office in a safe place that's calm and life is not really happening in that office space necessarily. And so what we do, and kind of this no four walls concept, is going into the community, into schools, into the grocery store, into the movie theater, into these, areas in the community that it's maybe not so safe. And so I think we get this opportunity to send a paraprofessional, a PSR, or a BST type worker out into the community with these folks, in the environment in which they're going to be triggered, in the environment that makes them uncomfortable, and really get to walk through that with them. And you can't really rehearse that, I guess. It's really difficult to accomplish that in an office. And again, therapy is very, very important, but it would be kind of be like the analogy that I would use might be like I'm kind of a sports guy. So, if you're describing to a person how to play basketball, um, verbally and maybe drawing them a picture on the board and explaining the game to them doesn't necessarily mean that they're going to go sit on a basketball court and understand and be able to do it. And so, what these services are really kind of more about is, yeah, we might sit and talk to you about this game called basketball, but then we're going to walk to the basketball court with you. And we're going to walk through those things and walk through those errors that may happen and some of the discomfort that comes with it. And take some of these coping skills and redirective kind of techniques and incorporate those so that you actually get experience playing basketball versus just, maybe having a general idea of what it's supposed to look like. And what we also find is that, when we go do these types of services in a person's home, let's say, we tend to see a different version of them than we see when they're, sitting in our office. And not only that, but we also get to see an objective view of the dynamic in which they live. So, for instance, if we're doing PSR work with a 9-year-old child at their house, we get to see how their parents are parenting them. We get to see how clean the house is. We get to, look at all these other objective pieces, and then that paraprofessional that's doing those services gets to come back and speak to the therapist or the person that's in charge of that person's treatment plan and give them that information so that they have more collateral, objective view of everything versus just what that client is telling them while they're sitting in their office for an hour a week in therapy.
Josh, I really like what you're saying about the importance of skill acquisition and skill rehearsal in natural environments where people are, but also the glimpse into information and details, context of people's lives that can really also help to design supports that really do meet them where they're at. Sarah, you had previously spoken to us about the importance of accessing these services for youth and families. And I'm wondering if you can talk a little bit about your experience in providing psychiatric rehabilitation services, and how they have worked in your experience with children and families.
Absolutely. And I'll kind of piggyback off of what Josh had mentioned. Again, not to downplay therapy, but work looks a lot different with children, youth, and families, rather than, in an office-based setting. We offer or allow Medicaid offers reimbursement for psychiatric rehabilitation services. And I really see this as a complement to those therapy services. This is where that practice really happens. So you may be able to identify things in therapy, possibly parents of youth struggling have identified issues they may be seeing in the home. But having the ability to apply these psychiatric rehabilitation skills, things like PSR and BST, in that children's environment is critical to moving them forward through their treatment. You can talk about it all day in an office setting, but really being able to practice what does it look like for a youth to experience perhaps like what social competency really looks like. How can you practice something like that rather than talk about it through a therapy lens? We had seen in a previous life before I came to Medicaid, when I was working more specifically with children, youth, and families, we saw so much success with really moving the needle on treatment plans for these youth, and being able to incorporate the family dynamic. I think sometimes that gets missed when you're in a therapy setting. Sometimes we have heard, children maybe their behaviors are kind of acting as the identified patient, but being able to incorporate a whole family system through change is really an opportunity to help support the whole family system. Josh mentioned again, just kind of that parenting aspect, even being able to support through difficult issues and support parents through dealing with those outcomes a bit better.
I can imagine as families are navigating the treatment delivery system with their children, how sometimes they can feel isolated or disconnected from what is actually happening kind of in the room in the therapeutic setting with their child. Can you talk a little bit about the importance of moving beyond those four walls and really incorporating parents and parenting skills into some of the psychiatric rehabilitation services that are also available to children and youth?
Yes, and I would say, and I might be biased, but I do see these psychiatric rehabilitation services. Really, this is where the magic happens. This is where um, behaviors change. Again, it's a complement to what they're learning through therapy, but being able to be in a child's bedroom as they're throwing a tantrum with their parents behind them is really a unique opportunity. Also, any community setting in our school settings, um, at a park location where children, youth, and families have the ability to interact with real life situations. I think that's also kind of one piece that gets missed in a therapy setting is it's not currently happening. It's more about what they're experiencing or may have experienced in their past, but through use of really utilizing the community and in a home setting. This is where you have real life ability to kind of make changes, pull from practice and memories of those experiences.
Justin, in your experience, working with systems and maybe even in your own personal experience, um, can you talk a little bit about what you see as the essential role of peers in also supporting the psychiatric rehabilitation services and recovery?
Yeah, Stephanie. I mean, peers need to be integrated into all systems, right? And not just an afterthought. So when we think about where that would work is, you know, before, after, during, warm handoff. I mean, keeping that relationship and even when transferring to other programs, making sure they're connected and not just dropped like a hot potato. But building that trust and that relationship in that process of a PSR, psychosocial rehabilitation, is important because for a lot of people, they have a lot of distrust of the system. Because of maybe bad experiences, maybe their own trauma, maybe their own distrust with earlier in life, and it's something that is similar. You're being sent to a center or to get treatment, and they're saying just trust everything we're saying, and they say, well, the last person that said told me that, didn't end up too well, or they didn't follow through on what they were going to say. And peers really can help bridge that gap and help support somebody and break it down to them in a common language of what needs to be done and what to support them, and really empowering the individual to make choices that they want to do, and that know that this is a pathway that they can use to make their lives and dreams become a reality. But sometimes we have to take a step back and do things a different way than we're taught or than we want to do them. I think peers play an excellent part of that, and also continuing the relationship through ups and downs, right? And keeping connected to other supporters, right? Not just the peers, and getting permission to share with the team and say, hey, I know you're not doing well. Can I reach out to somebody on your behalf? Can we make this? Can we walk into this appointment together? And it's not to do something for them. It's to empower them to do it on their own so they can sustain and live well years after this intervention is over. That doesn't mean they can't be connected to peer support, but it's a great way to get people on the path and keep them moving forward.
One of the things that I'm hearing you really emphasize is the role of peers in sort of the psychiatric rehabilitation recovery stance also being key for continued engagement. Um, can you speak a little bit about how peers really work as sort of the glue to help people stay engaged in comprehensive services as they need it, and certainly as they move through sort of maintaining recovery?
Yes, yes, in all areas, like before, during, and after, right? So let's say somebody's being discharged, right, and they're finished with the program. They should have some kind of warm line, some kind of people to reach out to them. And peer support is perfect through that, to keep that relationship and to make sure that during that transition that they have, that person in their corner or somebody they can rely on to call or to text because the older I got, the longer I did this stuff. And people didn't call anymore. They started to text you. If you get a phone call, I mean, it's uncommon these days. But I think peers really play a pivotal role in that support and in the psychosocial rehab and you know really just engaging somebody to continue with treatment, but not to like, because they're not treatment, right? Peers aren't clinical, right? So we're not here to say, take your medication this many times a day, because if that was all recovery was about, was medication and appointments and follow-ups, there really would be no life worth living. And peers really have to draw and paint a picture and get to know what somebody wants and their desires and dreams to work with them to live a life they want to live and know that it's beyond that. It's beyond, like Josh said, these four walls. It's beyond this institutional clinical setting that life, uh, you don't know what directions it's going to go, but to stay positive, stay on the path, and, miracles can happen.
Josh, you've been doing some work with peers within rural Nevada counseling, and you've even talked about pathways from potentially being an individual that's served by the CCBHC to more of a supported employment structure where they can move into being a peer of the CCBHC. Can you talk a little bit about some examples of some peer-led models or peers being part of the team in providing psychiatric rehabilitation?
Yeah, I mean, we've had actually, at our specific agency, we've had a handful of folks that were one time a client that now are, employees. I actually have one of our past clients that's actually part of my management team currently. It took about 7 years for him to get there. I have another one that, started out as a peer and then became a KDAC, a substance use counselor, and then recently went to grad school and now they're a licensed LCSW. Um, so we've kind of seen that progression, numerous times, I guess, internally. We're small. I mean, we're rural, so like, it's probably more common for us than it might be in like a bigger city. But I think that the other piece that comes with that is, peers have a unique outlook that I think that maybe not any other, if you look at all the other core services, I think that peers have something to bring to the table that no other portion of those nine core services do with that lived experience, right? And when it's in our case, when we have these folks that have kind of come up through our program, um, they bring a perspective as a administrator myself. Like I love to listen to them. And all of their ideas are not great. Like I don't want to make it sound like every idea that they have I implement because I don't. But they bring a perspective that I wouldn't be able to get from anybody else. And so they may come and they may bring to the table, um, hey, I think it would be better if we had this, or hey, what would you think about incorporating X, Y, and Z into this program, or I think this would make things easier on the clients. Like they have a perspective that I really appreciate at times. And again, not saying that I'm going to implement all of that, but I can definitely say that taking some of that input and listening to them has been something that's been beneficial for us. And I think that, kind of the side by side or the parallel work, I guess, that peers, in like the psychiatric rehabilitation, I think I would call it parallel in a way. And I know that it does cross a little bit and there's some, blurred lines there sometimes, but we have a pretty active team approach with how we operate. And so everybody kind of knows what the other people are doing. So if somebody's receiving PSR services and they have a peer support specialist that's working with them, and they have a case manager and they're getting meds and they have a therapist, all of those people are communicating on a pretty regular basis to update their treatment plan and figure out where they're at and what's working and what's not working. And what I would kind of point out is, again, doing peer work. We do a lot of that in the community as well. Like we a lot of our peers and the work that they do, we do some in the office, but a lot of it is not. A lot of it's out in the community, introducing them to different supports in the community, or kind of bringing that lived experience and giving them some support in whatever aspect that they may be experiencing. Um, and it's very, listening to a PSR and a peer have a conversation together, is pretty informative. Like it's super cool to listen to them. Hey, this is what I'm seeing and this is what we did. Oh, we were talking about that too, but this is what they told me. Because what I found is that clients tend to be more honest with peers than they are with any other type of provider. Like sometimes the peers will get a little more raw of a version of the client. And so taking those two things together and the PSR can gather this information from the peer from that different perspective and really kind of incorporate that the direction of the therapist or whoever's managing the treatment plan. Now they have this better, bigger picture of like, oh, if I would have known, now it makes sense. This is why they were acting like that. I'd never thought about that. And so working together is super beneficial. And again, I think the peer piece um, is kind of like brings this kind of more informal, comfortable dynamic to a very what could be perceived as formal, stressful process, if that makes sense.
It does. Justin, you looked like you wanted to jump in here.
Yeah, I love what you said about that lived experience, guiding the way, because who knows the system better than somebody that's experienced it themselves, and to give, your team, to have a peer on your team and to give that perspective of what an individual is going through, and to make changes necessary to better serve everybody you're serving, not just that one person. I mean, that's really what it comes down to when, you're backing up what you're saying about incorporating people with lived experience, right? It's making changes based on, that direct experience. And I think, what you said about being raw with somebody, I mean, agreed 100%. You're going to be, you even Josh, you're going to be more comfortable speaking to somebody with your friend not during the work hours, right? You're going to be more real with somebody than in a setting like this. So it's just proof that, this does work, and it sounds like you're doing a good job, and to keep it up, man. So thanks for doing that.
We've had quite a bit of conversation around the role of peers. I'd like to pivot a little bit to talk about the role of psychiatric rehabilitation in really supporting social emotional development, as well as facilitating inclusion and integration into the community, and really supporting people in meeting their goals. Um, Oftentimes, there is a debate between what would qualify as habilitation versus rehabilitation. And I'm wondering, Sarah, from your perspective, what do you see as the differences between what qualifies as habilitative versus rehabilitative services? And can you explain the difference between those two types of services?
Yes. So, coming from a Medicaid perspective, if anyone's familiar with how Medicaid works, it is based on federal authorities and gaining permission for different types of services to allow for benefits for individuals to utilize. It often is perceived as pretty bucketed or siloed types of perspectives, how benefits are approved. Some of those differences relate to habilitative versus rehabilitative. Habilitative services, I conceptualize as really services where individuals are gaining new skills or learning things for the first time, whereas rehabilitative services are really intended to restore individuals to a certain level of functioning or even improve skills. We've talked a lot today about recovery as well. So recovering, rehabilitative in nature type of services. But I would also just recommend really understanding kind of in the background as services are being delivered, the intent behind the service that's being delivered. Um, and it's also important to be mindful of individuals and their different diagnoses as well. And just understanding, is someone able to benefit from rehabilitatively from a skill? Or is it more of maybe an intellectual disability, perhaps that may have more success with habilitative skills? So that's kind of how I think of the difference. A lot of the skills we're talking about today are really supportive in that rehabilitative space. So that's where a lot of these types of services, whether that be through the CCBHC model, but also the services that support psychiatric rehabilitation, really live in kind of that rehabilitative section of Medicaid state plan.
I can see that the assessment and screening on the front end, but also throughout the duration of care, can also perhaps parse out what skills may be more habilitative in nature versus rehabilitative in nature for people. And we know that care within CCBHCs is driven by a comprehensive assessment, far and beyond standard diagnostic assessments. Justin, from your perspective, why is it important that clinics use assessments to focus on areas for intervention that include things like activities of daily living or independent activities of daily living? And how can they best engage individuals in learning more about life areas that are part of their goals of recovery?
Well, I experienced that personally. And I think education has a lot to do with it. And, beyond incorporating peers into this process, I think, you know, when you're not doing well, you don't, if you're depressed, if you're going through, especially symptoms of a mental health issue, you may have issues, showering and hygiene and, things like that and not even know it. And that's where a lot of stigma comes in around some of these illnesses too, unfortunately, as when people are down. And I think I had a counselor tell me, and she just looked at me and she had a really nice way of telling me. She said, if you can't brush your teeth, try to rinse your mouth out with water every night, she'd tell me, at least try to do that, to try to get, meet me somewhere. It's not to go all in and like, listen, you don't smell good, you're not brushing your teeth, it's obvious, you're dressed but instead of making me feel worse than I already did, really just try to like bridge that gap of communication. And it was little gestures like that that really helped. And I think, as far as personal stuff like that, as far as cooking and cleaning and grocery shopping and importantly managing medications and how to do that and how to do that if you have substance use or alcoholism in your life, how to try to stop to do that so those medications can work too, so those other things can take effect, and you can live a better life. And I think it's really patient work, and it's really really getting trust from the people that are engaging to for them to understand. And if you're letting them into if they're letting you into their homes and meet them in public places, you get a picture of what things are like. But to make that next step, you just have to go about it gently. And I think sometimes if we push too hard, we can push people away too. And that know that change is slow and progressive and doesn't always happen all at once, even though we see things from the other side that why don't they just do this? Why don't they just do that? And it's really grace, and just being there for the long run to support somebody. And I think peers, again, that real talk. Hey man, come here. If you're gonna come to court, you got to take a shower before you go to court. Talk like that, and it lands differently, right? So
I appreciate you focusing on issues that sometimes could get overlooked, like basic self-care, personal hygiene, and the like. And I think oftentimes there's an assumption that when someone presents for treatment and they walk across the threshold of a clinic, that they're ready, willing, and able to engage at all levels. And so oftentimes we, especially within CCBHCs, have this whole compilation of services that we're able to offer and provide to them, and sometimes that might be too much too fast. So it seems to me that the screening and assessment process, as people are coming in, really understanding where they are related to stage of change, is incredibly important. Josh, do you have some tips for successful implementation of assessments to help to inform treatment and recovery planning, specifically around the lens of psychiatric rehabilitation?
Yeah, I think so. I mean, I've done a lot of trial and error, I can say for sure. And I think that I think one of the mistakes that both on like a clinic level and a state level that I've seen is and it's hard not to, right? But like we pick this one, document or this one evidence-based tool that we're going to use, and think that it's going to be like this one size fits all thing. And I think that that's a mistake. I think that, when we're looking at, even kind of going down the ADL route, right? Like if we're looking at hygiene and some of these pieces, assessing that for a 40-year-old that has, a psychotic disorder looks a lot different than assessing that for a 9-year-old that may have, some kind of behavioral issue or whatnot. And so, having this kind of one size fits all screening, I think is probably not the best way to go. And I think that, and every state's different with their requirements and their, how much flexibility they have on this particular topic. But I think that, you know, having things come from a place more so that like when clinically indicated makes more sense than having there just be like this long checklist of screenings and assessments that have to be done no matter what. Now, having said that, I know that, it's really some people are going to strongly agree with that and some are going to strongly disagree with that because that can make it a little bit more difficult to track data and, standardize things. But what I've learned is that, and I think anybody that works in this field can say that pretty much everything that we do is gray. Like there really is not much black and white with how we operate. And so I think that looking at, so what we've done, kind of with all the trial and error and trials and tribulations that we've gone through, is we've kind of built into our EHR system what we refer to as like if-then logic. So like we may have one document or one screening tool that we use, but it kind of has this tree that if we answer yes, then there's other stuff that needs to come with that. And if we answer no, then there doesn't, or vice versa, versus just having kind of this blanket thing that everybody has to do. And the other thing that I would throw out there is every client is different and every client responds differently to, standardized screening tools. And so like if we take, for instance, like a PHQ-9 or a Columbia suicide screen or kind of one of these usual suspects that everybody, typically uses. You have some clients that listen to a PHQ-9 and we're going over a PHQ-9 and they're looking at their MDD symptoms and they're like really excited to see what their results going to be and say like, hey, what's my score going to be compared to what it was last week? And then you have these other clients that are like, really, we have to do this again? I don't know. Like, this is a waste of my time. I just want somebody to talk to. And I think that it's really important for not just clinicians, but any direct care staff that's going to be involved in these screening processes, case managers, whoever it is, um, to kind of have some workflows and some understandings around that. Like there absolutely has to be a standard, there has to be a minimum, there has to be an expectation. But we also have to be able to shift gears based off of where the client is at and what they need. And if what we're doing screening wise, and again, maybe this is kind of more on the state level or certainly, executive leadership level of clinics is like if we're going to use a standardized tool, which we are going to, what happens when that becomes a barrier or that becomes a burden for the client and that really takes a safe environment and a healthy environment, an environment where the client wants to engage and it puts them in this place where they no longer want to. I think that there needs to be talk about that and procedures and workflow for such things. And then the other importance with that is with those standardized tools and with those results that come with all of those different assessments and screenings, let's look at the data and let's shift, right? Like if there's a pattern that we see, we do, kind of internal assessments on a pretty regular basis. And if we're starting to see a pattern of, oh, we're seeing more adolescents with higher PHQ-9 scores, what should we do with that? So I think like taking some of the data from, these standardized tools and incorporating that into like a continued quality improvement plan or quality assurance plan or like a move forward plan. Like there's a lot of good information that can come out of that as long as we're not scaring people off with paperwork, right? I think that's kind of the takeaway that I would really throw out there is that it's really easy as a CCBHC with all of the required documentation that comes with it. It's super easy to scare people off, both clients and staff, right? So finding a way to, make it work so that it's beneficial versus looking at it like a technicality, I think is a really big, important piece.
There's a lot there that I'd like to unpack. Before I do that, Sarah, looks like you have something you'd like to chime in on.
Yes, just listening to Josh talk about operationalizing the model, it has been a really exciting initiative for me to be able to help implement this model on the Medicaid side. Within Nevada, this model came about. I think we received approval back in 2020 in our state plan for this, with it being effective in 2019. But with this model, understanding the specific requirements of it, we were able to provide some flexibility within this model as opposed to some of our traditional behavioral health outpatient services, and being able to kind of let go of the reins a bit on like prior authorization requirements and service limitations really has been able to let this model flourish a bit more, and in effort to meet individuals where they're at. Having, the clinics be able to provide maybe an array of services or maybe one service, whatever that individual is ready to accept. So it has been kind of a non-traditional Medicaid foot in the door for behavioral health. And there are obviously lots of data requirements and paperwork requirements as well, but that information all leads to improving our Medicaid policy around this as well. And we can really connect the dots on how treatment is delivered in a behavioral health setting with the support of our CCBHCs, being able to provide, active information, and has really just helped kind of grow the model in Nevada and excitement around it. I'm hopeful that this contributes to kind of newer thinking as well in that Medicaid space on how to implement benefits. So just wanted to add that.
It actually really connects with one of the things that I wanted to elevate from what Josh was talking about, and that is this balance oftentimes that states are trying to strike between standardization and meeting requirements, right? We know that we have certification requirements that CCBHCs have to meet, and that those criteria tend to be relatively well spelled out. And then what happens when we also lean into the flexibilities that states have in really interpreting and understanding the spirit of that certification criteria and how clinics are able to exemplify whether or not they're meeting that criteria. So, from a state perspective, Sarah, can you talk a little bit about how you've seen CCBHCs exemplify the use of psychiatric rehabilitation services and maybe some examples that stand out, and maybe just applying this lens of flexibility that you were talking about and how important that has been throughout the CCBHC journey from a program standpoint in Nevada?
Yeah, absolutely. Traditionally, in our kind of traditional form of behavioral health outpatient services, it often may feel like for individuals that are in need of behavioral health services, they kind of have to go through a step-by-step process in order to find the service that's going to actually propel them forward. Whereas within CCBHCs, being able to utilize a whole array of services including psychiatric rehab services outside of prior authorization requirements and service limitations, I think engages individuals a bit faster on their track towards treatment. We've talked a lot about being able to deliver these services in the community. And I think just speaking to the spirit of CCBHCs, that is our goal. Like we want services to happen where that individual is, whether that be in a school setting, which we've seen a lot of CCBHCs have great success in integrating services within our school settings. Some counties are more acceptable of it than others, so it's kind of working our way towards that. Absolutely, but I would also just add just throughout the kind of certification process, walking through the process of getting certified as a CCBHC, I think it's incredibly critical that a state team is along in that journey with that individual CCBHC, just understanding some of the barriers that maybe the CCBHC may be experiencing. It's going to help the state team grow as well as the CCBHC team grow. In Nevada, we've had a really collaborative effort throughout those processes, and I think that is hopefully gained interest in this model and really provided awareness around the model and not even just for interested providers, but kind of getting the word out for individuals seeking services as well and understanding the model a bit more.
There's no doubt that states have a significant role in laying out the requirements for CCBHC services in a really clear way. And Sarah, you're talking about really states partnering with their clinics as they're becoming CCBHCs, but also throughout implementation. Certification requirements often include states coming up with who's qualifying for services, what is the required documentation, how are clinics monitoring individuals' progress towards their goals? So, for treatment planning, monitoring, and the like. Um, States clearly have a role in ensuring that high quality services are being provided through CCBHCs. Are there any valuable lessons, Sarah, from your perspective, that you and Nevada have learned about the certification process, and maybe some recommendations for other states that are early on in their CCBHC journey about how to maybe build in some of those flexibilities and really partner with clinics?
I think that 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 really hits it on the head. It's really a partnership between the state as well as providers. Just speaking from when I began at Medicaid, learning alongside our CCBHCs and oftentimes at Medicaid agencies, Medicaid can kind of be seen as outside of a provider, and it's almost a siloed effect happening. And being able to partner alongside CCBHCs as both teams are learning, whether that be the state team and the CCBHC team, I think is really imperative. I think having a good relationship with your state partners kind of allows for learning along the way. So oftentimes when Medicaid comes in, providers might be resistant to providing their full experience or even identifying what barriers they might be experiencing, or maybe I made a mistake on this. But within Nevada, our approach has really been to learn alongside with them. We have a really robust certification process before CCBHCs get certified, just to make sure that CCBHCs are ready for that lift. As Josh mentioned, it is definitely lots of paperwork, lots of evidence-based practices as well. But I think having that partnership is critical, and just active collaboration. Nevada does quite a few site visits as well, and really kind of hands-on inside the documentation of CCBHCs and recognizing all that's being documented. We also have a lot of data collection requirements that add towards a quality incentive payment. So again, emphasizing how services are being delivered, and then being able to reimburse for more of an incentive of following those data requirements as well.
Josh, I'd like to turn to you. What advice would you give state leaders about the services that fall under psychiatric rehabilitation and establishing requirements for CCBHCs? Maybe, Justin, if you have thoughts, you can go first.
I have thoughts. I think that, we really need to listen to the people that we're serving better, and that when we're making some of these requirements, does it make sense, right? Does it make sense for the community being served? Uh, all those things, not just the people, what everything else looks like, you know, um, and working together as a team, policymakers, frontline staff, community, family members. I mean, this is really what we need. We need all stakeholders at a table when we're trying to make the system better for anybody, to serve anybody. And what looks like in Nevada, in rural Nevada, may look different somewhere else, which we all know. So that's what it's about.
Josh, any advice you would give state leaders?
Don't live in a box. I think that, this no four wall concept is, I've learned in the CCBHC model, it really is invaluable for the functionality of how this model operates. And I think that the states also need to follow suit with that, or start, I guess, suit with that, in a sense of um, get creative and understand that when you're providing these types of services in the community with paraprofessionals, like it is not a black and white process. And so having some creativity and some flexibility in that, I think, is super important. Again, kind of to piggyback on Sarah, not having to do prior auths, and being able to just shift with people as things change is super important. The other thing that I would love for to see, like if there's states who are, writing policy, or they're writing their standards, or they're really trying to kind of implement this model, before you do, go out to a couple clinics that exist and go right around and see what this looks like. I think that it is again, going back to the basketball analogy, I guess, um, just because you look at a bunch of data and statistics on a piece of paper doesn't mean you know what's happening on the court. And so I think it's really important. Um, and I agree with Sarah also that, you know, having a core team at the state with different sets of eyes from different departments that have different expertise is also very important. Having somebody, you know, a Medicaid person or somebody that's really kind of financial driven. Um, and, you know, having somebody that kind of maybe more understands the administrative oversight piece, somebody that's kind of on the clinical side, so that it's not all the powers that be at the state making decisions looking through the same lens. I think it's important to have different lenses that are being seen, maybe even having advisory committees or something along the lines to get some input other than what we're seeing just on paper and data. But really, I think, like I have experience with, um, you know, both sides of the state, you know, having policy and procedures come up with from a person who doesn't really know what we do, compared to having a person that has been here and seen it and done it, and seeing the policy and the expectations and the standards that come from those folks on the state level that truly know what we do makes a lot more sense. And I think that you're going to get a lot more participation and openness from administrators at clinics if they really can look at you and say, like, oh, this person actually came out here and watched us, versus who is this person? Where are they getting this information and these standards from? If that makes sense.
It absolutely does. I know that we only have a couple of minutes left, but I'd like to just remind everyone, we've covered a lot of ground in just a short amount of time. Um, Talking about the difference between habilitative and rehabilitative services, looking at what some of this state oversight needs to look like, or how states can really look at the spirit of CCBHC certification when designing and supporting clinics and implementing these services. The importance of getting outside of the four walls and really utilizing your peer workforce to support and extend the availability of some of the psychiatric rehabilitation services. The importance of having flexibility, even with screening and assessment on the front end, making sure that we're meeting people where they're at as they're coming into clinics, and making sure that we use that as an opportunity to really support them in being engaged with services versus prescribing services directly to them that they may not necessarily have buy-in for. So before we wrap, I would just like to go around the virtual room here and ask each of you if you have any parting words of wisdom on psychiatric rehabilitation for some of the state partners that may be listening to the podcast today. Um, Justin, may I start with you?
Yeah. Parting words for today. Well, this is the first podcast, I believe, and you can't see our lovely faces, but if you did, you know we were grateful to take part in this event. And I think that when you're building these systems and reviewing it, we have, great experts in you, Dr. Woodard, Josh, and Sarah, and really appreciate all your thoughts and comments. And that when you're building these systems, please have these stakeholders I mentioned, lived experience voices, families, justice partners, law enforcement, everybody in your community at the table when making these decisions. And I thank you for this opportunity.
Thank you for joining us, Justin. Josh, any parting words of wisdom that you'd like to impart to our state listeners today?
Re-emphasizing, I guess, what I already said, and that if there's room to be flexible, obviously with standards, there's got to be standards and there has to be expectations. Um, Please entertain that, I would say, and understanding in kind of the psychiatric rehabilitation services. I really hope, like a lot of clinics that I've worked with, they really are focused on therapy when they're building these clinics and they're building these org charts and workflows, and their focus is really kind of mental health therapy. Um, we really need to emphasize these paraprofessional services, in my opinion, because I think that for certain populations, not all populations, but for certain populations, I would argue that these services are more effective at affecting change than actual therapy is. And so don't overlook it, I would say would be the short version. And when you're not overlooking it and you're coming up with policy, understand that it can be we can handcuff people if we put too tight of terms on it and put it in a box. So let's take down the four walls, all around as much as we can.
Thank you, Josh. And Sarah, any parting words of wisdom you'd like to share?
I would just like to reiterate, as I said before, psychiatric rehabilitation services are really where the magic does happen. That is where movement is made. But I would really encourage state leaders to truly understand each component of those services because service delivery does not look like it does when it's on paper. So having a really good idea of the intent behind maybe what a service provider is doing as it relates to what's on paper is ideal because it doesn't look the same. Um, but so having that full understanding of the service is critical.
Thank you all for joining the conversation today. I certainly have enjoyed the discussion and really do appreciate you each sharing your unique perspectives on psychiatric rehabilitations within CCBHCs. And I imagine our state listeners will appreciate the guidance and direction that you've offered as well. Thank you all. Take care.
Thank you.